On a busy street, everyone is walking, focused solely on their own path, annoyed that others are in their way, slowing them down, forcing them to step to the side, stop, or feel rushed. But in the sky, we can see the alternative. A murmuration reminds us that we were never meant to move alone, that listening is a form of strength, that moving together can create something larger and more beautiful than anything we do alone. When organizations on the ground move together, forward, yes, but also side to side, always with a common goal in mind, and allowing energy and resources to flow where they're most needed, we create something bigger than fear, than worry, than despair. We create hope. And we keep that hope alive and moving through the work we do and the connections we make. Being here together today is an act of hope. Hope for a better future. Hope for an end to the syndemic. Your presence makes our murmuration bigger. Let's see what impact we can make together.
Welcome to this afternoon session to talk about the epidemiology and realities of Manitoba. And we have a super panel with most enthusiastic people working and trying to support Manitoba during this epidemic. My name is Yoav Keinan. I'm a professor at the University of Manitoba, Department of Medical Microbiology and Infectious Diseases and Internal Medicine. And it's my pleasure to welcome you and introduce the speakers of this session. I'll start by a land acknowledgement. The University of Manitoba campuses are located on the original land of the Anishinaabe, Niniwak, Siniwak, Dakota, Oyote, Dene, and Inuit, and on the homeland of the Métis Nation. We respect the treaties made on this land, and we are committed to working together collaboratively to make better realities in the future in the prairies. I'll start with a clinical case that highlights some of the challenges that we face here when dealing with new diagnosis of HIV. And this is a case of a 18-year-old woman who has a history of abuse, all forms of abuse, sexual, physical, psychological abuse during childhood. She is now unstably housed and currently injects methamphetamine. She's diagnosed with HIV as well as co-infection with syphilis, chlamydia, and gonorrhea. She's a victim of intimate partner violence where her partner basically forces her to have sexual encounters with friends in return to substances. And she is prohibited from and prevented from attending medical or any other form of health care. This is the history in terms of her HIV markers. Her CD4 count, as you can see here, is high initially with a viral load that was 17,000 copies. On February of 2019, she attains the undetectable viral load. Question to the audience, what facilitated that? What helped her in getting the undetectable viral load? I won't wait for an answer because we've lost time due to audio, but the thing that happened is unfortunately incarceration where she was able to take her antiretroviral therapy. But some of the other things that we see that sometimes allow people to connect to care and achieve undetectable viral load include solutions to housing or to unstable housing, people who become housed and have some support services. During pregnancy with the tightened ability to reach people in order to obtain frequent appointments and try to assist in getting an undetectable viral load for protection or prevention of mother-to-child transmission, as well as some people who are connected to a stable opioid agonist therapy. That's where we see the ship turning towards undetectable viral load. And unfortunately, at the end of incarceration, people return to frequently to previous living circumstances, and it's reflected here with the detectable viral load. And after that, there are life events that impact the ability to engage in care and to be retained in care. Like for this person, it was loss of custody, unstable housing, and then COVID-19 hit and resumed the methamphetamine use. The reason we put this slide here is just to start with the reality, and then we will talk with three excellent speakers about how we try to change those trajectories. Our speakers for the session today, I'll introduce them in the order that they will speak, and we will go with presentations of each speaker for 15 minutes, after which we'll take questions for all speakers at the end of the three presentations. The first speaker is Dr. Zulma Ueda, who is a professor at the Department of Medical Microbiology and Infectious Diseases and Canada Research Chair. Zulma will present some of the epidemiology of Manitoba, and the work that has been done by Dr. Ueda has helped shape and deliver data and information that drives decision making. The second speaker will be Amanda White. Amanda is an incredible, passionate advocate who works for the PATH program, and she will introduce herself and tell you a bit more about herself, but the work they're doing to support people where they are and connect them to services that are needing and to navigate a complex system or systems will be displayed. And last but not least would be Marjorie Schenkels, who is a peer leader working with All Together for Ideas and with the Women's Hub. She's a fierce advocate for supporting people living with HIV and people who are struggling in Manitoba. And it's been a tremendous pleasure to know Marge for several years and to work with her for the last few years. And you will hear her story, so I will not introduce her at more length because her story speaks for itself. So, without further ado, I'll hand over to Zulma.
Hi. Hi, good afternoon, everyone. Welcome to this session. I will stand up. It's my way to deal with being a bit nervous before every speech. The second reason is I fell down the stairs, so it's more comfortable for my feet. So today I will share some of the findings about the HIV and STI epidemiology. I will not focus on that. Many of you may have heard several times our findings. To start, all my research and all the research that we do at the All Together for Ideas Research Consortium is publicly funded by the Canadian Institutes of Health Research mostly, but everything is publicly funded. I have received an honorarium from Gilead and ViiV, but none of these companies have influenced any of my presentations, and they have not contributed to any of our research. Today, we will share a bit about the current HIV and sexually transmitted and blood-borne infections epidemiology. That is the acronym for STBBI in the prairie provinces. Some innovations across Manitoba, a concrete example of co-creation and meaningful engagement to develop the All Together for Ideas research team grant. And finally, what ended up in what we are currently doing. In all my presentations, I always start with the faces of our research. So we are here today, but actually behind us there is a huge team of people. So I always start with the peers. With the peers, so you can see here a beautiful and incredible team of people who have, they are people with lived experience and guide all our research. And they propose and lead community outreach activities that we perform throughout the years. So a huge shout to them. Also, the guidance of a huge research advisory committee, but I want to highlight the elder Margaret Lavalle and Chantal Daniels, who have been instrumental for us to perform completely our research since inception until dissemination of the results. Also, I want to show all the researchers that are behind the scenes, all the principal investigators. I want to shout the incredible HIV team in Manitoba, Dr. Keenan, Dr. Casper, Dr. Lauren McKenzie, Dr. Lori Ireland, Kim Templeton, and Mike Payne. When we started in 2021, they were fantastic. And it has been thanks to all the advocacy and leadership of so many people that made possible what we do, and more important, all the changes that our data generated. Also, our incredible trainees, our incredible staff, and many other researchers that have supported our research. So what I'm going to share today is thanks to all these incredible people work. So to start, the HIV and SVB epidemiology, some of you saw this figure yesterday. So here, what I'm depicting is, this is 1977, and this is the latest 2020. In this graph is 2022, but I added 2024. And you can see that the black line, this is incidence, a number of people newly diagnosed with HIV per 100,000. And you can see that the peak in Canada was in the 90s. And overall, Canada has made tremendous progress. So that is a huge improvement. However, this green line that you see here is Manitoba. And Manitoba is the only province in the history of Canada that over time has reported a trend in increasing in the number of cases. One important thing is this line, this peak is Saskatchewan. So Saskatchewan and Manitoba consistently have reported 3 to 5 times higher incidence of HIV in the country. This is the latest report that you saw yesterday. Canada reported an incidence of 5 cases per 100,000 people, and Manitoba and Saskatchewan reported 19 respectively. What I want to highlight is that the population of Manitoba, Saskatchewan, and Alberta represents 16% of the Canadian population. However, between 2021 and 2023, these 3 provinces contributed between 35 to 40% of all new HIV diagnoses in the country. The other thing that I want to highlight is that Manitoba, this was a study led by PHAC, and Manitoba has the lowest HIV PrEP use in the country. And women have the lowest prescription overall. And in a recent paper that was published early this year, people who inject drugs have 0%. So women and people who inject drugs have very low uptake of HIV PrEP. I prepared this slide to summarize all our findings. So when in Manitoba, people living with HIV experience multiple co-infections. So close to 60% of people have previous diagnosis of sexually transmitted and bloodborne infections. It means a missed opportunity to have been prevented the HIV acquisition. 12% have skin and soft tissue infections, and there is a significant proportion of pneumonia, tuberculosis, and endocarditis. So one of the main messages is people are not only diagnosed with HIV, people have other co-infections. But we can do something with our current tools. So one is if you test for one STI, test for all, offer actively pre-exposure prophylaxis or post-exposure prophylaxis for HIV to the person when they have an STI diagnosis, or to the sexual partners. Offer vaccines recommended for people living with HIV. In our research, less than 50% of people, and for some vaccines, less than 10% have received the vaccines recommended for them. Test for tuberculosis infection. And one important thing, harm reduction supplies prevent not only overdoses, they can prevent endocarditis. Clinicians have seen an increase in endocarditis infection. People also experience multiple morbidity, so there was a significant proportion, over 50% of people reported mental health or have a mental health condition. Over 70% of people use 2 or more substances, of which the drug of choice was crystal methamphetamine. And this disproportionately affects women. And there are other morbidities. People also have hypertension, diabetes, and any other diseases. So here, the important thing is people newly diagnosed with HIV require mental health support, require that we build healthcare systems that provide addiction medicine, opioid replacement therapy, and multidisciplinary approach with other teams. And lastly, but probably the most important of all of them, is social and structural determinants of health. In our cohort, 43% of females and over 30% of males were experiencing houselessness. A significant proportion of females, over 80%, were experiencing intimate partner violence, food insecurity, limited access to care service. So in this case, we as a system can provide social support workers, transitional housing and shelters. We can guide our patients to go to domestic violence support services, sexual assault, intimate partner violence program, and offer extended working hours. So if I can summarize our epidemiology, this slide summarizes completely how we can better support people living with HIV, in particular in the prairies. All of this will help us to decrease the incidence and prevalence and mortality. So regarding innovations across Manitoba, I want to show a few, but there are many more. I will not talk about each one of them, but I just wanted to acknowledge that there is a significant number of community-based organizations, community organizations that are doing incredible work in Manitoba with different programs, doulas, mobile healthcare clinics, many other supports that provide participants living with HIV. Also hospitals, the HIV clinic at the Health Science Center became a super low barrier multidisciplinary team that support people living with HIV. They manage over 70% of the people living with HIV. And currently over 90% of people refer to the program. So bottom line, there are incredible organizations that you can see here that are doing exceptional work, that are trying their best to try to bring innovations to the table. I will present a concrete example, but I want to show what we do with that concrete example. So this is our approach to research. So everything starts with community consultations, and we have in place a meaningful and culturally safe approach. So everything starts with community consultations. Then we have all our research. Once we have performed this, we propose our research that our research is multidisciplinary. And with this, it's not just focused on basic science, clinical sciences, it also includes social sciences. We have criminologists, we have lawyers, we have psychologists, we have mathematical modeling, etc. We perform the analysis, a huge team of communications. We generate the evidence, and with that evidence, we do a lot of advocacy to make changes. And then all the decision-making and evaluation and implementation. So this is the concrete example. This was the community consultation that we performed last year. It's not the only one, but it's the most recent. So we partnered with several organizations, and we decided 4 objectives: to listen deeply to the most marginalized communities in Manitoba, to center community priorities, to build trust and act together, and to share knowledge and keep growing together. So this team was composed by the All Together for Ideas Research Team Consortia that is based at the University of Manitoba, but has multiple partners: 9 Circles Community Health Center, the University of Winnipeg, Manitoba HIV Program, Aboriginal Health and Wellness, and Ceylon Mission with partnership with CAHR. And here we perform extensive amount of consultations. Consultations can be brainstorming session, meals, outreach. We went to the encampments. We performed huge number of activities, and we co-created all the community consultations together, and then we performed the consultations. In these consultations, we heard over 400 voices that included over 230 clients and community relatives, more than 58 staff and healthcare providers, and over 50 directors, managers, and public health workers. The community members included community relatives, including men, women, and gender diverse people who self-identify as indigenous, people who experience houselessness, food insecurity, use drugs, or people who self-identify that belong to marginalized groups, or people that have been diagnosed with any sexually transmitted infection. We implemented 10 different strategies that I summarize in 4. So anonymous input, there are people that don't like to disclose their names. We provided drop boxes, anonymous link, QR codes, post-it boards, group sessions. So we had brainstorming circles, post-it boards, one-on-one conversations, and creative approaches. So art-based session, meals, working sessions, and so on. These are just some of the pictures of the different strategies that we implemented in each one of the organizations, including we joined the mobile healthcare clinic of the Aboriginal Health and Wellness. We also went to the encampments to listen to people. The main priorities for people are 4, and in this order, the main priority was housing. People need housing. The second priority was mental health. The second priority was drug use and addiction. The third one is mental health, and the last one was healthcare services. These findings allow us to understand that when people are experiencing survival needs, survival threat, the priority is not the HIV. The priority is having house, having a mechanism of coping using substances, or I've just provided some examples that people told us, and deal with mental health, anxiety, depression issues, a lot of trauma during childhood. So based on these consultations, we proposed a team grant, and that is the example that we created. So we propose shelters as a public health opportunity because people are there. So instead of waiting for people to go to hospitals, we reach out to people. So in this case, we propose the one-door, one-stop, which is a community impact. We aim to do a community impact and cost effectiveness of a point of care and public health interventions within emergency housing shelters. So people go to shelters for multiple reasons: food, shower, laundry, harm reduction supplies, or anything. And whatever the reason, bring the person to the shelter, actively offer prevention strategies, testing strategies, and treatment strategies. So within the prevention strategies, actively offer vaccines. We hope to have PrEP this year. We offer education and harm and sexual friendly education and condoms, and harm reduction supplies that is provided by the shelter. There is also testing, confirmatory testing. We take the samples there, and the person doesn't need to go anywhere. And we offer treatment for STBBIs, opioid agonist therapy that is provided by 403 to pharmacy, and alcohol anti-craving medications. The human resources are many, but we still need a permanent presence of physicians. So far, the research team is the one that has been providing this part, and incredible volunteers that go to Silo. I will not spoil, I invite everyone to the presentation of Dr. Keenan this afternoon. He will present some of the results at 5 p.m. But I just want to say that many people say people don't return. And in our case, over 90% of people have returned for their results. And we have been successfully in treating over 80% of people. So if we implement resources on the spot, people will accept treatment. The only thing is people don't have to go anywhere. So this was a question that Gilead posed me, something surprising and actionable we found in our community consultations. The most surprising to me is that throughout these 5 years, I have been privileged to work and to listen to over 600 people, mostly heterosexual and marginalized population. And to my surprise, none of them knew about HIV PrEP. That was the most striking result for me. For me, it was a given, but none of them knew what HIV PrEP was. So what is actionable? We must train and advocate about HIV pre-exposure prophylaxis for prescribers. Prescribers don't know or they don't feel comfortable. Community members. And one important thing is we need to tailor to different populations. One size doesn't fit all. The second one was that over 400 people, we asked the question, how you would like to learn about HIV, STI, substance use. And the number one was watching TV. They want to watch videos or resources in the TV, listening to the radio, to interviews, and people told us everywhere people listen to the radio, and create short videos of 2-3 minutes that deliver a single message per video, and seeing poster or infographic based on bus stops, clinics, very visual and very little words. In conclusion, in 2026, we have the best testing, the best prevention drugs, the best treatment for HIV. Yet, we have the highest rate of HIV in the prairies. Completely unacceptable in a high-income country. We must implement a preventative approach. We need to prevent that people acquire HIV rather than constantly being reactive. And HIV requires for the prairie provinces an intersectoral system secure and provide wraparound services and support. Please remember, with the case that Dr. Keenan provided, people newly diagnosed with HIV are facing survival needs, unstable housing, childhood trauma, intimate partner violence, street violence, human trafficking, mental health issues, substance use disorders that prevent people to focus on their own health. Thank you.
Well, now I will hand it over to Amanda.
Hello, everybody. So I'm a little nervous today. I'm just going to throw that out there now. This is my first time presenting, so I appreciate everybody coming to listen to me today. Thank you. So I'm currently an outreach worker with the PAS program at 9 Circles. PAS stands for Program to Access Treatment and for HIV and Supports. I come with lived and professional experience. So I will let you know a little bit about myself. I've been living with HIV now for 12 years. And when I was first diagnosed, I would never have thought I'd be sitting on here at this stage and talking to however many people are here today. Thank you. It took me until about 2021 to finally find my calling. I knew what I wanted inside, coming from a background of trauma, addictions, mental health. I knew what I wanted, but I didn't know what was out there until one of my friends came up to me and started telling me about peer support. And I'm like, that's what I want to do. So I went in it. My career took a different path. I went into working with a different nonprofit, nothing to do with this. And I kept my retail job again, and I found a lived experience group with 9 Circles, which opened my eyes up a lot and found people like-minded like me living with HIV. I didn't feel like the only one out there. I felt like, hey, you know what, there are other people out there living with it. And it's grown me so much. I've been able to be on the board of directors of 9 Circles. I'm with PAS Outreach. I've got to travel. And it's taking me out of my comfort zone talking here today, which is huge because I didn't talk about my diagnosis up until 3 years ago. And I think the more we talk about it and the more we create awareness for it, the more people are going to open up and the more we're going to break the barriers and break the stigma of it. Because you know what, we're living happy, healthy lives, and we need to show people that are struggling that they can get there too. I was once that person that struggled with addiction, mental health, and the trauma, and here I am. So it can be done, and they need those people with lived experience to support them and walk the walk with them. Thank you. So now, sorry, I brought my notes because I thought I could see it, but I guess I can't. So I'm going to go through some of the guiding principles of PAS. So hope, respect, and belief in growth. Practitioners maintain a hopeful outlook and respect each individual's potential for learning and professional development. Cultural relevance. Services are tailored to be cultural sensitive and inclusive, and recognizing that culture plays a vital role in recovery. Shared decision making. Individuals are active in their participation in their care with practitioners, facilitating collaboration and honoring personal choices. Strength-based approach. Focus is placed on what individuals can do, building on their existing skills and their capabilities. Person-centered care. Services are customized to reflect each person's unique values, goals, and aspirations. Community integration. Recovery includes full participation in community life with individuals exercising their rights and responsibility as citizens. Self-determination and empowerment. Individuals have the anatomy to make their own decision and about their lives and the services they receive. Natural and peer supports emphasizes in place on being personal supports networks, including community resources and peer-led initiatives. Holistic quality of life. Recovery is not just about symptom reduction, it's about improving all areas of life: social, residential, financial, educational, occupational. That's how nervous I am. It works. Okay, so health and wellness promotion. Individuals are the key collaborators in wellness plans. They are with their wants and their needs in the forefront. Accessibility, integration of services. Services are available when needed and coordinated across medical, physical, and holistic domains. Okay, there we go. So some of the features of PAS, we are a team-based approach. So we have different pods. We have 3 different pods around Manitoba, and they consist of nurses, social workers, outreach workers, peers, and HIV doulas. In the moment services, PAS provides in community care settings rather than office and clinics. These may include agencies, drop-off shelters, encampments, residents, correctional facilities, just anywhere the client is, we will meet them where they're at. Small caseload. PAS consists of about 40 clients per pod. Time and limited services, which is really nice because we can have people on our caseload for short periods of time or all the way up until lifetime. It goes on their needs and when they're ready to graduate from the program. Flexible service delivery. PAS pods meet frequently and use shared schedule in order to respond. and fix point of responsibility rather than sending clients to all different providers. We meet them where they're at. That's why we have the social worker, the nurses, the outreach workers to help support that. Sorry, I need some water. Okay, so I'm going to start it off with a little story, because who doesn't love a little story? So when we first met this client, she had loose association thoughts, short window of tolerance, and unable to engage in full conversations. She struggled with day-to-day survival and access to food, housing, and income. She was alienated from her family and was living with generational trauma, and she had an OI, which affected her cognitive behavior. With our team efforts, a lot of effort it took, we finally got her to go to the hospital by ambulance. We were able to get her there, step one. And then it was work from there, because she had a very high risk of AWOLing. There was many times we had to talk to her, get her to stay, until finally she stayed. That was a huge win for us. We were so grateful for that. So here we are, 6 months later. She sustained a suppressed viral load. She's raised her cognitive behavior. She's connected back with her children and gaining custody. Stable housing, engaging with medical and social supports, abstaining from substances, connecting back to culture, and attending social circles. And this is my favorite part. This brought tears to my eyes when I was driving with her. She said to me, quotations, "I look back when I was sick and I saw angels walk into my life." It shows that this really does work. Outreach paths really does work. And it makes me happy knowing that our hard work that we put in is actually doing something. Okay, some of the community barriers that PAS helps address is stigma and discrimination. So we have non-judgmental harm reduction. Mistrust in the healthcare system. A lot of our individuals have a lot of mistrust in the healthcare system, so we support them by building long-term relationships, supporting the clients to gain that trust, taking it one step at a time to help support them do that. Housing instability and houselessness, meeting people where they're at. We don't expect them to come where we are. They don't have to have a fixed address. If we have to come to your encampment, if we have to come to a back alley, wherever, we are willing to meet you anywhere you're at. Poverty and basic needs. We help navigate financial, foods, and the medical system. Cultural barriers, culturally safe, trauma-informed care. Stay curious about different cultures, creating a safe space, avoiding the one-size-fits-all. And in addition, PAS is guided by the Indigenous Health Framework. Okay. And some of the biggest successes of PAS is increased engagement among the people living with HIV, previously disconnected with services. And if you want to look at any of the data, you can look on the Manitoba HIV program report. All that information will be located there. Trust built through consistent outreach, relationship-based care. This takes time, and every person is different. Nobody's going to be the same, so you have to get to know how to work with that individual. Participate supported in maintaining treatment and improving health outcomes. Promoting independence. Breaking tasks into steps that feel more manageable. Normalizing setbacks. And reassuring that things happen and not to be hard on themselves. That no matter what, we'll get through it. We just do it over again or take slower steps. And then breaking barriers which are holding people back. Identifying the barriers which hold clients back and working through them with clients. So some of the ongoing challenges, systemic barriers such as poverty, housing instability, and racism, limited engagement, instability for follow-up, mistrust in the healthcare system, past stigma, harm reduction service, and trauma, complex client needs, resource gaps, and long wait lists. Some programs don't fit people's complex needs, and if so, there are long wait lists for these resources. And relationship building remains essential for long-term engagement. And who doesn't love another story? I love telling our good stories. So I'll just go on about this one. So this was the gentleman that was that still is in our program. When we first met him, he was houseless, had specific mental health, never was on ART for the 7 years living with HIV. He had frequent visits to the ER. It could have been daily, weekly. He was very high at the ER, going for food and shelter. Our team would struggle to locate him, the client, since he didn't use any of the social services. He suffered from intellectual capacity and the lack of trust in services. With consistency and persistence, we were able to connect him back. Being able to connect, I just realized it. Being able to support him and get him a suppressed viral load and getting him on an injectable ART, and also to supporting him with his mental health with an injectable. I just found out today he's back living with his mom and being able to eat traditional foods off the land, which makes it huge because he hasn't had community connection family connection in a very long time. So that really warms my heart knowing that he has a place to stay. He's eating home-cooked meals. Like, that's a huge win. And he's still living with a suppressed viral load. Okay, so just some stories from the field here. Real stories help illustrate the humanity and complexity and complex outreach work. Clients often feel overlap barriers such as housing, stigma, and health challenges. Relationship-based outreach and reconnection people can care and support. Okay. What others can adopt from PAS? Persistence. Not giving up on people. Continue outreach even when engagement fluctuates. If they're not ready, maybe go back the next day. Maybe go back the next week. Don't give up on them. Always be there when they're ready. And just let them know that you're there when they're ready. Harm reduction. Care without abstinence. That's what we're there for. If they need support, yeah, sorry. No matter what, we welcome people into our office, no matter what. Connection to culture, connecting clients to cultural organizations. System navigation, walking systems with the client rather than sending them away. Okay. What system changes would strengthen the impact? Better integration between HIV care, mental health, addiction, housing, and primary care. Greater investment in peer-led support roles. Improved access to housing and social supports, and continued work on stigma in the healthcare systems. So my closing remarks would be, outreach and peer support and community-led care create systems that do work. Compassionate relationship-based care improves engagement in HIV services. PATH ensures people that are living with HIV are seen and supported and never have to face HIV alone. Thank you.
Now hand over to Marge to tell the third part of this conversation, and I remind you that keep your questions and we'll have them at the end of the 3 presentations.
Thank you. Yellow flower turtle woman. She's cautious, stays safe in her shell, and carries the world atop her shell. A woman who has seen the dirty, the messy, the corrupt, the lost, and in all that, she sees the trying, the beauty, the growth, and the found. A turtle who sees all perspectives. Big story. At first diagnosis, I had shut down. I understood what the doctor was saying. I heard him speaking, and all I wanted to do at the time was just give up. I already knew at that time that HIV isn't a death sentence. I was aware of that. But the year of 2009 was already hard to cope with, and now I have an HIV diagnosis to cope with as well. I didn't want to tell my partner, but I understood that I needed to. And I was afraid of how he would react to my diagnosis, as he had already gotten violent with me 2 weeks prior, when that I had learned I had chlamydia. When I told him, he cried and he asked why I didn't tell him sooner. How could I? I had just found out myself. It would have become 2 of the worst years of my life, because for 2 years I lived in darkness, and I was just waiting for death to take me. So I made some wrong decisions, and I got myself in trouble. I had hoped that if I had gotten into enough trouble, maybe then I could possibly be saved. It kind of worked. I came from a small town where everyone knew me and respected my family and respected me. The police, the Gimli RCMP, were in shock when twice they had to bring me in for questioning. I had been charged with having HIV. At least that's what it felt like. I had let the constable know about the rape that had happened nearly 3 years prior. Now nothing was done. And why I never bothered to press charges. The Winnipeg police were right there, and they drove by. All they saw was just another Indigenous woman crying out for fake help. And I learned that night there is no such thing as justice. So, on my last suicide attempt while living, I had heard this song that saved my life. God, who will love me for me? Not for what I have done, not for what I can become, but love me for me. I learned how to love myself. I learned that my parents loved me. I knew my sisters loved me. I knew that I had aunts and uncles and cousins that cared about me. I had people in my life that would be sad if I had unalived myself. So I came back to the city, and I got myself put back together, and I found support. I got into some financial trouble before my non-disclosure charge, and I was on probation. My probation officer was my first real action supporter. He helped me accept help. He led me towards 9 circles. He sent me in as a referral for me to start receiving food bank. Then from there, I got more involved with our beautiful HIV community. I wanted to do more than just participate in bingo before food bank. So I asked how to volunteer. Next thing you know, I'm prepping the coffee, I'm getting the snacks ready, I'm making sure that we have everything ready for bingo. We would have our dietitian come in once a month, and I had offered to help her create a nutrition bingo to help her get her important information across. I am the first woman in Manitoba to be charged for not disclosing my status. But is that my full story? No, it's just a part of it. In one of these articles, I learned that confidentiality is a joke when it comes to HIV. As you can see in these articles, It's my confidentiality, my right, being exposed to the entire world. I had no say. It's just small town girl. My high school best friend's mom even wrote to the article right there, I can't believe this could happen in our town. And now when I say that the turtle in me sees all perspectives, as hurtful as these articles are, and as there's some truth, but there's a lot of lies. But the good that come out of it, an entire town, an entire high school, they all went and got checked. Because if quiet girl Marge can get infected, the one who's super sheltered and doesn't do anything wrong, if she can get infected, anybody can. So there's the happy perspective in that. I found faith in the church. I knew in my heart that whatever happens, happens for a bigger picture, whether for me or for someone else. Eventually, some women from Sisters of Fire took notice to me, and these sisters would become my family. And it is thanks to my Sisters of Fire, my lived experience peers, who accepted me without judgment. They held me up when I couldn't stand. They encouraged me when I felt doubt. They wrote letters to me while I was incarcerated and pregnant with my first. It would be these same sisters who helped me shine and pushed me to get my voice heard. With Sisters of Fire, I learned about culture and traditions, and the one thing that my faith and my culture have in common is my personal relationship with my Creator. 2012 was a year of major growth, and it was very true when they say that growing pains hurt. I was forced to finally accept a diagnosis that I had been in denial about. I finally got started on my AARTs because I had been charged for not disclosing that I have a virus. I had a church family that prayed for me and just asked that His will be done, and that I know there are reasons for His artistry. I had a clan of sisters and allies that wanted nothing more than to fight. I wanted to fight too, but I didn't know what we were fighting for. I didn't even fully understand what I was going through, so I just went with the flow. Whatever your will, it be done, Lord. When I got sentenced, I froze in place. I knew in my heart that I was going to go away, but I didn't want to, because I finally had a family. Why would Creator do this to me? I was pregnant at the time and was very hormonal. Once I dusted myself off and got back up, I was still afraid to speak up for myself and afraid to speak to the correction officers. But I had cellmates that would speak up for me and get the help that I needed. When I was ready and understood how things worked, I got brave and I found my voice. Why would Creator do this to me? I wish I could say that I found my voice while with the Sisters of Fire. But really, Creator has a weird way of doing things their way. I had to speak up for my unborn baby who was growing inside a positive mother. They tried to change my prenatal care, and under normal circumstances, that would have been fine, but my baby is different, and I needed to keep our specialists to ensure that my baby will be born negative. And that would not have happened if I didn't use my voice for the sake of my unborn child. And through making sure I got things done correctly, my correctional guards got the chance to also be educated. Every doctor's appointment, I encouraged my officers to ask my doctors any questions they may have had. Yes, this appointment is for me, but when are they going to get a chance to learn? I had a different kind of experience than what most would speak of when being incarcerated. A common prayer. I stay safe in the hands of God and Creator, and that His will be done. I felt protected while incarcerated. I had girls that looked after me and my unborn baby. I had correctional officers that made sure I got a bed and not the floor. While getting induced with my baby, the doctors took their time, and my correctional officers were kind and supportive. They helped me any way they could, made sure I didn't go hungry, or let me know that they wouldn't judge me if I needed the painkillers. They shared their own personal stories with me, what it was like to be the one giving birth, or even what it was like being the one watching their wife give birth. It made me feel like a normal human and not a prisoner. I was induced December 20th, 2017, and Lukey was born December 23rd. My correctional officers didn't have to, but they let me have Christmas morning with my baby. I could not have asked for a better team, and I still look back on those days with love in my heart. It was my Headingley family that advocated for me, and they spoke for me to the parole board. And I know that it is thanks to them that I got to come home. My sisters of fire were ready to greet me back home with open arms, and I was ready to fight with a better understanding of what we are fighting for. HIV is not a crime. While on parole, I got pregnant with my princess. My induction was not as comfortable with her because I did not have my officers. The nurses were not as kind or as gentle, and Sarah was born within 7 hours of inducement. The doctor had physically broke my water with her hand and then went ahead to make me push 3 centimeters too early. But by the time my baby girl was born, I had nearly bled out. I continued to bleed out during my moon time, and it was a heavy flow that would last up to 15 to 20 days. And after a few months of this, I got a full hysterectomy done, just to stop the bleeding. I cannot have the tons of children that I had wanted, but I have my 3 precious loves and a bunch of street children. Again, Creator working in mysterious ways. My daughter's first birthday was when we were told to stay indoors. COVID-19 hit. My kids were not allowed to play outside. The number of times we were threatened to be given a fine was ridiculous. And it was really hard staying indoors with 2 little ones and a school-aged one and a little old lady and 2 grown-ups. I just couldn't do it anymore. Sisters of Fire, and along with Love Positive Women, arranged a sharing circle via Zoom so we could stay connected. And twice a month we would meet on chat, share, and take care of our mental health. They would also send out care packages for us and our families. So once in a while we would get some hygiene, face masks, soap, coloring, arts and crafts, and reading material. It was a little lifesaver for our family. What happened after COVID-19? We continue to meet. We have a sharing circle every month, and it's where Gani Ganichik is kind enough to lend us their space for food and sharing and drumming. My children are a big part of our circle too. We enjoy helping with the spirit plate and going to place it outside for our ancestors. I love the community that has helped me teach my children about our culture that I am also still learning more about as well. Just before COVID-19 hit, one of my Sisters of Fire was asked to recruit some lived experience people for a project. And this is where I met all together for our ideas. So much personal growth has happened while being with All Together for Our Ideas. We sat together bi-weekly and talked about what we would like to see happen and how can we put our ideas into action. As a team, we created a presentation about HIV in Manitoba and what the numbers look like in 2021. We have done 6 outreach events where we went out into community and gave out big lunches, extra snacks, along with harm reduction supplies and resources. We've also cleaned up our community parks around springtime to help Mother Earth. Our team talks about what they want to see happen, and I like to make things happen. I reached out to a resource that I had accessed, and I asked to do a presentation. And with that same resource, our team was able to hold an education bingo at Wanda City Balmoral location. We had bingo prizes and giveaways, such as bath bombs and hygiene care packets, with resources to healthcare, food banks, soup kitchens, really any resource that the people need. We tried to help give more accessible resources for showers and other help. My need to put our ideas into action got me noticed as a leader, something I never really saw in myself, but glad for the support and the encouragement. I am now a peer support peer navigator. My role is to be with my peers and help them feel more comfortable when doing the surveys. I do my best to make our area feel safe and non-judgmental, and sometimes I'll have coloring pages that have to do with our theme of the month. For example, in February, I had Love Positive Bodies, Survivor ribbons, and prevention pages. I also had Valentine cards, mental health matters, and for March, I have St. Patrick's Day colorings and word searches for the theme of March. For April showers, I had printed out some calendars and some cleaning lists. I give people a chance to talk about whatever they need to get off their chest. I also have a bag of candy for participants or clients. So who doesn't appreciate a little candy every now and then? I love the work that I do. I love the feeling of giving back to a community that had helped me grow and become a better person. I'm healthier and happier than when I first got diagnosed. I've lived through abuse, houselessness, substance abuse, and so much more. And now I am a woman living with a sleeping virus. I am a mother of 3 beautiful negative children. I'm a sister, an aunt, a cousin, and a friend. And I accept all humans as how they are. After all, if I want to be loved for me, they deserve to be loved for themselves. Running White Wolf, she who leads. I never thought or dreamed that my spirit names would be so drastically different, but it also shows where I was and who I am. Thank you to my sisters for believing in me and giving me the push and the love I needed. Thank you, Gani Ganichik, for giving us a home to meet and be together. And thank you, All Together for Our Ideas. Thank you, Zuma, because without you guys, I would not be sharing my truth with all of you today. Thank you.
Okay, so maybe we have 7 minutes. You've heard 3 very good presentations and very powerful stories, personal stories. There are several takeaways from this. Maybe I'll leave the slide so you can read. We won't go through that, so we can leave a little time for conversation, and I see lots of teary-eyed around me, so I'll try to bridge that. So maybe we'll start with anyone who has questions can make their way to the microphones, and there are microphones there. But I will start with the first question to Amanda. Is that okay, Amanda?
I guess so. Put me right on the spot, why don't you?
Amanda, so you emphasized working towards independence as part of the goals of PAFs. How do you go about achieving that? What are some of the examples or story that you want to share?
The biggest thing is walking alongside of these clients. These clients have had so many mistrust in the healthcare system, and technically we are a healthcare system. Like, we help people with their health, and so it's gaining that trust and walking with them, taking them to their appointments, helping them with their medication, helping them like get to food banks. Like, I know there's been a client where we've gifted her a gift card and taken her grocery shopping, and so, okay, you have this money, you've got to budget it, and supporting them budgeting, whether it's getting their own place. We have our OT at Nine Circles that went out and supported clients with cooking for them to gain that independence, because you can't take somebody from an encampment and put them in a house and expect them to thrive on it. It's not going to work. It may work. I can't say it's never going to work, because some people may be able to, but you have to walk with them on the journey step by step, seeing where they need help to gain that independence, and not have us with them all the time, or have to rely on other resources and have their own space.
Thank you. I see hand in the shining lights there.
Hi, just a comment. Amanda, I met you a few years ago. I guess we were competing for the same job. And for some silly reason, somebody directed us, or directed Amanda in a different direction. And I'm so proud of her, because the work she does is amazing. And for Marjorie, I've heard you speak before, but I've never heard you speak like you did today. Thank you so much.
Thank you, Ken.
Maybe I will ask a question to Marge. So, Marge, in terms of your work as a peer, what are some of the supports that you need as a peer to be able to support others in the community?
I still attend the monthly sharing circles, and even outside the sharing circles, I have other connections with friends that I do call my sisters, and they're always there when I need them. Having the community I didn't have in the beginning, having the support that I didn't have in the beginning, that's what's been helping me move forward presently.
Okay, so I'll go with another question to Amanda.
Okay.
So everything in our healthcare system is limited by resources. If you had additional resources to support PATH, how would you invest in them? What you would enhance the PATHs with?
Oh my goodness, that's a loaded question. I see my team here being like, okay, come on, everybody, give me ideas. No. Honestly, having more teams with the situation we're currently in right now and how HIV rates are going up, is building more PATHs teams. Our team, especially with the complex clients, our social worker is working her butt off. Everybody does. Okay, I shouldn't just say we all do, but having more access to mental health, supporting with diagnoses, because it's so hard to get into psychologists or to get those diagnoses. And a lot of the programs, you need these diagnoses to get into. If you don't have that, they're like, no, sorry, we can't help you. So just being able to have a better connection, I think that would be my main one. And the second one would be having more PATHs. Is there any government people in here for funding? but that would be my number two. And just like, I don't know, like I've seen a huge impact being somebody with lived experience and being able to share with clients. I don't share it all the time. There's a time and a place to share it and tell them, you know what, I can say I've been there where you've been before. And when they hear my story, I don't go into details that I'm living with HIV, they're like, really? And it just, I think having that lived experience as a part of it too was really, really amazing because it gives people hope that they can live a healthy life, they can do whatever they want in life, and just having more of those lived experience roles out there.
Thank you. And I'll ask Dr. Rueda one question. Okay, I will skip that and I will...
No, I wanted, I have the opportunity to share presentations. This is the moment for them, not for me.
So, Marge, in terms of the activity and the leadership that you've taken, what are some of the challenges that are still faced to support peers?
My personal challenge is, even though I go to siloams daily, I'm still really quiet, and it takes me a while to initiate people to come see me. But once I get a lay over who's there and who looks approachable, then that's when I'm ready. I'll pull out the coloring stuff, I'll pull out the candy, and then they come. And it makes it easier when they come to me, then I don't have to go there.
Thank you very much. We're coming close to our allotted time. I wanted to thank the incredible speakers, Dr. Rueda. We have to discontinue in a sec. So I wanted to thank the speakers, Dr. Rueda, Amanda, and Marge, for really impactful. I feel privileged to be on the same stage with you. And I wanted to also thank Gilead for putting this together and supporting us through the preparation of this, and also for their help and advocacy for the prairies. They've been here consistently behind the scenes supporting the programs, even when things are rough. So really, Gilead has been a presence, and I want to thank the team here. Thank you, everyone, for listening to those stories.